We begin with our keynote speaker, Deputy Secretary for Health, Courtney Burke. Courtney Burke served most recently as the Commissioner of the New York State Office for People with Developmental Disabilities. Prior to that, she served as Director of the New York State Health Policy Research Center at the Rockefeller Institute of Government, the public policy research arm of the State University of New York. She previously worked as the Senior Research Scientist in the Rockefeller Institute's Health and Medicaid Studies program. Prior to joining the Institute, Ms. Burke worked at the New York State Department of Health and as a Senior Policy Analyst at the former New York State Office of Advocate for Persons with Disabilities. Ms. Burke received her Master of Science degree in Health Policy and Management from SUNY Albany and her Bachelor of Arts in Political Science and Journalism from the University of Connecticut. Let's give a warm welcome to Secretary Courtney Burke.
Thank you. Good morning. I want to acknowledge the conference sponsors. Thank you for bringing this excellent panel, and acknowledge my co-panelists as well, and thank you for the nice introduction, Commissioner. I also wanted to acknowledge my colleague who is from the State Office for Aging, the Director, Corinda Crossdale, here down in the front. So as you all know, this is a very exciting, I guess it depends on which word you want to use, exciting and challenging time in healthcare, and particularly, I think, a time of opportunity as aging services are so important as the population gets older. I think there are a lot of things that have been changing that are for the better, and I want to touch on some of those today, and I am here to talk about what I see as the opportunities in front of us right now as all of these different changes are going on. I guess I would start by asking the audience to think about, if you could create the ideal system of care for people, what would it be like? And while you're thinking about it, I'll give you some of my thoughts that really stem from, I think, where the administration of Governor Cuomo has tried to head. One thing that is certain, I think all of you are very aware, is that we've tried to ensure better care coordination, and that is through managed care changes. But it's also about the integration of services so that people don't feel like things are disconnected for them. So care coordination is certainly a big theme. Person-centered care is the second big theme, and that's a term that I use, but people may see it as sort of outcome-based care, care that people want to have in their lives, and how do we make that possible for people? As people who are working on the front lines, I think you know what that means. People will tell you what they would like in their lives, and we want to do more of that. We want to make it less medical and more about people's lives and outcomes. I think there's also been a big focus on community-based care, letting people age in place, moving people out of less institutions and into community-based care. So what are the opportunities in front of us now that will help us get there? Well, this is a list of some of those big major programmatic changes that present us with those opportunities to achieve those things, to achieve person-centered care, to achieve care coordination, to look at outcomes for people. A lot of acronyms, but I think most of you are familiar with all these. And what I'm going to do today is go through some of these different programs, talk about them, some in more detail than others. Some of them I may skip through the slides and allow you to sort of look at the details yourselves. But then I'm going to talk about the opportunities when we get to the end. So the list includes, obviously, as was already mentioned by the Commissioner, the Medicaid Redesign team, which the Governor convened when he came into office to look at how do we restructure our system in a way that we can contain costs but improve quality for people. Gathered the best ideas from people all across the state, and then went through a process of implementing Medicaid Redesign. DSRIP. Now this is a new one. DSRIP is Delivery System Reform Incentive Payments. This is another thing to keep in mind. As many of you may recall, part of the outcome of the Medicaid redesign team process was, okay, we're saving all of this money, we're improving outcomes, let's go ask the federal government if we can keep some of that savings and reinvest it. So that's what we did. We went to the federal government about 2 years ago with a big application for a Medicaid waiver. This spring, the federal government finally said yes to that application. And for those who were aware of that process, there were things in there about aging services. Now, people have seen the final agreement with the federal government, and they've said, Well, I don't see aging services in there in the same way that it was when we first were talking about this. And I'll get into this when I talk about it, but aging services and the types of services that you provide are very much a part of delivery system reform. Third I have up there, and this is the only place you'll see it in my presentation, is Olmstead, which is a Supreme Court decision that was made over a decade ago about the right of people to choose their services to live in the community. This has been something that's been very important to the governor. He convened an Olmstead cabinet who had to come up with an implementation plan of how do we actually, as a state, make sure that we're true to the principles of what was in that decision about giving people choice in the services that they're receiving. Fighta, another great acronym, is New York's version of integrating services for people who are duly eligible for Medicaid and Medicare. The Balancing Incentives Program, another great acronym, BIP. We had a great saying during our budget process this year of, what are we going to do? Well, let's just BIP it, which means let's use this opportunity to see what investments we can make. This is a time-limited investment that the state can make to rebalance its services so that people are more likely to have services in the community. And this is a great opportunity for the people in this room because there are investments that I think will be helpful. And then finally, SHIP, which is the State Health Innovation Plan, which is basically the Department of Health's 5-year strategic plan for improving population health. So those are all the things that are going on right now. It can be a bit overwhelming. It's a lot of acronyms, but it's also a tremendous amount of opportunity. Medicaid redesign. So I'll go through each one of these things in a little bit more detail about what they're about and the populations and services impacted. Most of you are familiar with Medicaid redesign and the recommendations about managed long-term care. So this is the recommendations that actually came from the Medicaid redesign team. It's looking to help people who are chronically ill and who need health and long-term care services, such as home care, to stay in their homes as long as possible. Fighta is a federal opportunity which seeks to integrate care and services by blending those two funding streams. Just a little bit more on Medicaid redesign team recommendation number 90, which is specifically about mandatory enrollment in managed long-term care. We did get approval from the Centers for Medicaid and Medicare Services to begin this process. So it expands the managed long-term care for Medicaid members who are also eligible, the dual eligibles as they're referred to, so that they can receive services in the community. One important thing about this is that the costs of skilled nursing facility services are included in the capitation payment. And I think that provides a financial incentive because nursing homes can be much more expensive to see if there are ways to keep people in their homes longer. So the rollout, and you may or may not be familiar with the timelines, has begun in mostly downstate, and it's going in phases where different counties are participating in the managed long-term care program. We are, when you look at that, we're about phase 5 right now, and I'll go into more detail. Phase 5 is really the rest of the state enrolling in managed long-term care. We had submitted to the federal government an amendment for approval to begin the mandatory enrollment of people in upstate New York June 1st. We haven't heard back from them yet. So if I were to place a bet on whether things would begin on June 1st, given the date today, I would say probably not. But we are optimistic that it will happen sometime this summer. So these are just the counties and when the rollout timelines apply. In terms of looking ahead at other timelines, there are certain waiver programs. You may be familiar with these, the nursing home transition and diversion waiver, the traumatic brain injury waiver participants. Those people, the dates are further out, so we have more time for them to enroll. Nursing home residents, as I mentioned, June 1st, it's only people who are newly in custodial status, so people who are already in the nursing home, it doesn't necessarily apply. It's only if you're newly enrolling. So this is just some basic facts that I wanted to make sure everybody in the room was familiar with the information and data, and I have to credit my colleague Mark Kissinger from the Department of Health, who oversees long-term care services, for putting together a lot of the slides on managed long-term care. In terms of the services, now these hopefully look familiar to you. These are a lot of things that you may already do in your aging services network: adult day health care, personal emergency response, nutrition, congregate meals, very important services for making sure that people can live in their homes and communities. There are certain populations that are exempt or excluded. So some people can't join managed long-term care. Just wanted to make sure that you all know who those populations are. So these are traumatic brain injury waiver participants, nursing home transition diversion clients. I should note, and that's why there's a star next to some of these, that even though this not, they are exempt and excluded, the participants can choose to disenroll from those programs and participate in managed long-term care. So it really leaves the choice up to them. So how are we doing so far? What is our experience with managed long-term care? I think it's been probably better than most people might guess, or it's been more expansive than most people might guess. When you look at total enrollment, we've seen a pretty significant increase. Since 2004, we had about 10,000 people who were enrolled. We now have more than 128,000, and those are pretty recent numbers, so that was April. The number of plans participating in managed long-term care has grown significantly from 16 to 46. And this was interesting. This is information that I got from Corinda at the State Office for Aging, that 62% of area agencies on aging are currently currently serving 13,000 dual eligibles, and they're receiving managed long-term care type services. So to me, that's a good sign that it's not going to be that difficult of a transition. And in fact, a lot of those partnerships may already be happening. So along comes this new program. Under the waiver, the state received permission to receive approximately $8 billion over the next 5 years to keep savings that we're accumulating from our Medicaid program from changes that we've made. And this new program, Delivery System Reform Incentive Payments, is all about outcomes for people. And what it does that's different than what might have been submitted just a couple years ago in our original Medicaid application is that it's very focused on outcomes for individuals, and it encourages providers to work together. So the first thing up there is collaboration, collaboration, collaboration. We want to see providers working together, integrating services so that people get that seamless experience of getting all the services that they need. And it's a very outcome-driven program. So you're not getting paid just to provide a service. You're getting paid to provide an outcome for a person. The third point up there, performance-based payments. The entities that come together are actually called performing provider systems. And they have a motivation to perform and to improve outcomes for people, because that's how they get paid. As a state, we also have that same incentive to make sure that those providers are performing, because we have statewide accountability. If we as a state don't meet certain benchmarks in terms of performance, we will not get all of that $8 billion. So to me, some people may say that's a challenge. I say it's an opportunity to really create lasting transformation, to create the kind of changes that we need in our system. And I think it goes very well with some of the other changes that are happening right now. If you're more interested in learning about DSRIP, this is timelines as to how this is working. We've already heard from a number of provider organizations across the state. They have submitted what are called letters of intent, which is their intention to work together with a network of providers to try and achieve certain outcomes for different individuals. There will then be planning grants, so those provider organizations can plan how they're going to be able to reach those outcomes. We think that that planning process is really critical. So over the course of the summer, we hope to see those providers reaching out more widely to say, who else do we need in our network? Who else can help us with achieving these outcomes? And there's a menu of projects and outcomes that providers can choose from. Some of them are much more clinical, preventive health, managing asthma, managing diabetes. But some of them, I believe, are very closely related to long-term care, keeping people at home, keeping them healthy, keeping them out of nursing homes. So if you're not familiar with this yet, I would encourage you to take a look at the Department of Health's website. Just Google DSRIP, DOH, and you'll be able to find numerous materials. They've got a whole set of PowerPoints. They have what they call whiteboard presentations, which are sort of the simplified version. So hopefully you can get all the information you need from their website. State Health Innovation Plan that I mentioned is the 5-year strategic plan that the Department of Health put out last year, and we hope to get additional money from the federal government. We'll be applying in the next month. That will enable us to do even more around these different themes. So the themes in the State Health Improvement Plan include improving access to services, and you're on the front lines every day, so you know how to improve access, you know how to get people the services they need. Integrating care, which I've mentioned several times already about making sure that services are seamless for people. Making healthcare cost and quality transparent to enhance consumer decision making. So we're going to be developing our systems of showing clinical health information so that doctors can do a better job at getting people the services they need, so that the consumer can see differences in prices, they can see differences in quality. Starting to pay more for the value of services as opposed to the volume, which is very much similar to what managed care tries to do, is look at what is the outcome. We're not paying you to just provide a service. What are you actually getting as a result of that? And then finally, promoting population health. And I think, again, this is another great area for the area agencies on aging, because you're out there, you understand the importance of social determinants of health for people, about the importance of people not necessarily needing health care, but needing assistance with their rent or getting to certain appointments, which may not strictly be health care. So on to the next acronym, Fighta, Fully Integrated Duals Advantage. This is just a little more information about who's eligible on the left-hand side. I'm not going to go into the detail. You also have to meet one of the 3 criteria on the right side. It's looking at people who are nursing facility clinically eligible, or they're eligible for the nursing home transition diversion waivers, or they require 120 days of care. There are also certain populations that are exempt or excluded. Again, that's a long list, so I won't get into it, but know that there are certain populations, residents of OMH facilities, individuals under age 21. So it's not everybody off the bat who's going to be eligible for the Fighta program. Again, this is populations not eligible, so it's residents in intermediate care facilities, individuals eligible for emergency Medicaid, individuals in the OPWDD home and community-based waiver program. And I should just note that agency has also expressed interest in developing Fighta programs, but it would be done under a separate memorandum of understanding with the federal government. So Fighta services, the ones that are covered include services that are already covered through Medicaid and Medicare in New York State. And in addition, there's some other types of services that are covered, like wellness services or other services that just will do a better job at meeting a participant's needs. So this is the federal government's, I guess, favor to us of saying, here, we're giving you some flexibility. We're giving you the ability to better coordinate payment streams. Let's see what we can produce in terms of outcomes for people by allowing this flexibility. A couple of things that I wanted to note that I thought were interesting changes that providers might want to know about. So Fighta plans will receive an integrated capitation payment. Providers will no longer bill Medicaid or Medicare directly, so that may be a change for you in terms of how you're doing billing right now. And providers will bill Fighta plans for services that pays providers from a monthly capitation rate. So it helps, I think, ultimately, although not initially, but ultimately simplify the billing processes for providers. And then BIP, the final one on the list of acronyms, the Balancing Incentive Program. This is where I think they're probably, of all of those, there's the most immediate opportunity for funding to help local service providers with figuring out how to rebalance their services, make investments that they need to make that will help. So what BIP does is it provides the state with a 2% basically bump in the amount that we receive for our Medicaid services. And in order to get that bump, we have to make 3 changes, and those 3 changes are up there. We have to have a no wrong door / single point of entry network, and I think that this is, particularly for the city, this may be one of the biggest opportunities in terms of getting funding to create that no wrong door single point of entry system and make the enhancements that you think are needed. It also requires that there be core standardized assessment instruments and that there's conflict-free case management. So New York State was, our application was approved last March. We were awarded. I haven't seen a check yet, but I know that we will be awarded this money as the program rolls out. It's close to $600 million. So we were one of the states that received the most money. I don't know if that's because we need more rebalancing or whether our application was so good, but nonetheless, it's a tremendous opportunity. But again, I said it's time limited, so it's only April 1st until September 30th of 2015. So we've really got to figure out how do we get this money out the door and what things do we pay for that aren't going to have to be sustained later, that are more one-time in nature. So I think that this is our chance to enhance ongoing effort to improve access to home and community-based services. We've got to, again, just like the district program, we've got to make progress toward identified targets that were in our BIP application. And when BIP ends, we have to show how that increase in community-based services is going to be maintained. Just a little bit more about the No Wrong Door single point of entry, because I thought it would be of slightly more interest to this group than some other groups, and maybe I'm wrong. But the single point of entry, No Wrong Door, delivers consistent information. That's the goal, so that people know about what their options are when they're calling and need help. Whether they're calling, whether a family member's calling, whether a staff person is calling, we want everybody to get the same information. And it should provide information about a range of services that might be available. It also, we hope, would enable people to interact with a web-based screening tool, so that for those who choose to use a web as opposed to a phone, that would also be available. And then we also want to invest in some training tools to make sure that when this network is established, the information that's being provided is consistent, and that people who are working on the front lines, that there's a standardized curriculum developed. So we think those are all one-time investments that BIP can pay for. Again, this is similar to what I just said, standardizing information so that you're all getting the same experience when you call. Create that network of agencies that can help anybody who might need aging or long-term care services. There is will be a 1-800 number, and we hope that this will be our single point of entry as is required under the BIP program. So in terms of next steps and getting BIP up and going and out the door, we need to promote that whole concept of No Wrong Door, single point of entry as a gateway to information about long-term care services. So that's really something that you could do every day on the job. Agencies becoming part of New York Connect's network would transform their business model to conform with those operational standards. And again, we think that there's money here to help us with doing that. And then agencies will have to learn new systems in order to provide general information and be accessible to anybody who needs the type of information. So we think there's also some investments that need to be made there. So continuing on the theme of opportunities of managed long-term care, I do think that this is a very exciting time in long-term care, healthcare generally. I think that with the investments that we're making right now, and with the programs that I outlined, and with the goals that I outlined, that we will do a better job in the next few years of keeping people out of institutions, keeping them happier at home, certainly diverting admissions and readmissions into hospitals. New York traditionally has not been one of the best states in that area, and we have specific performance measures that we have to meet over the course of the next 5 years with the federal government in order to get investments from them. I think that it's also allowed us to focus more on preventive services, evidence-based treatments, things like social adult day that do prove to be very beneficial for people. Better quality, lower cost, better outcomes for people, coordination. I think it'll help us perhaps end some of the silos that exist. And I'm not as familiar with the city, so I don't know, the different programs and how things are split up. But I know at the state level, we have the State Office for Aging, but then we have all of the long-term care services that are paid for by Medicaid. And the two have not always worked so well together. And I think that this is a tremendous time and opportunity for us to make sure that those things are better coordinated, because the amount of investment we make in State Office for Aging services versus what we make in Medicaid, there's a huge disparity. But one of those programs, I won't tell you which one, but I'm sure you can guess, is a good investment and saving a lot of money down the road. And I think we need to see more of a balance. And I think that managed long-term care, BIP, all of these things will help us to do that. Again, opportunities with the Balancing Incentives Program. This is $600 million is a great investment. I was focused on those things of how do we build capacity, how do we provide financial incentives for community placement, how do we build the infrastructure that we need, and how do we make our operations more streamlined. I think this is also a good time to look at what opportunities there are in quality. When we look at what we've done thus far with managed long-term care, I was happy to see that it seems like we're doing a pretty good job, and that's in part due to the great input that we have received from providers like you, consumers of care, who have been very involved in our process for getting managed long-term care up and running. And the feedback has shown us that it's improved outcomes. The New York State Department of Health, on their managed long-term care report in 2013, found that 86% of enrollees' overall functional ability was stable or improved over a 6 to 12-month period. So that's a good sign that managed long-term care is in fact working for people. 84% of managed long-term care plan members rated their plans as good or excellent. 9% would recommend it to a friend. So those are, to me, good indicators that for the most part we're doing a good job and that this is in fact improving quality. And the last thing I added to this slide is that I think it also provides us another chance to look at how we view quality. And I think if we view it in a much more person-centered way that looks at things like, is a person happy? Do they have a support network around them? Do they have a person they can call when they need something? That a lot of times those indicators are much better indicators of quality care than some of the traditional ones that we've used. So I think that by bringing managed long-term care into the fold of managed care overall, we start to view the world a little bit differently in a more person-centered way. So opportunities for aging services providers. Many aging network providers have the infrastructure, and I think a lot of you are well positioned and prepared to engage with managed long-term care entities, and I think a lot of you probably already are. There are new opportunities with aging network providers who are not yet engaged with Medicaid clients. We've found that there are in fact a lot of people who you may be serving right now who are Medicaid eligible, but you don't necessarily know that. So we're trying to do some work at the state level of matching some of the data up, of looking at who is Medicaid eligible, who's getting services from the aging network. Can we actually be drawing down Medicaid dollars for some of those services? Because then we have basically twice the investment if we do that. And there's a lot of those services that you're providing that could be potentially, if a person is Medicaid eligible, could be paid for by Medicaid. I think the network that you have out there provides the same or similar community-based services as a lot of the, quote, medical providers, but you're doing it at lesser cost. And that's what this is about. It's about quality at a lower price point. And then in addition to provision of community-based services, I think the aging network is a great link for individuals and clients for a variety of other benefits and services. So these were some of the things that I was talking about, that social determinants, things that are less medical in nature, but that ultimately prevent people from needing more medicalized services. So that can be things like health insurance counseling, landlord mediation, and much more. So finally, in looking at the future, I think you're probably all a little bit overwhelmed, but there are tremendous opportunities. And there's a lot that has to be done to adapt and get ready. And I think certainly the workforce, BIP is one opportunity to invest in any changes that might want to happen with the workforce in terms of training about new programs. There's also, I think, this is something regardless of what's going on, if you're integrating, if there are times when there's people retiring, people leaving, is there a chance to be integrating your services more with another provider, really lessening administrative costs and working together? And it does. I mean, I think that you'll see more and more of that with different provider types working with each other, integrating. And thinking differently about the culture. We should be thinking more like you all have been thinking for decades now, about how do we make people happy in their homes? What is it that they need in terms of social determinants, preventive care? That's something that I think will be a culture change sort of with the rest of the healthcare system, not necessarily with you, but I'm hoping that more people in the health field will be thinking like you've been thinking for a long time. And it creates new models that are non-traditional Medicaid reimbursed services, falls prevention, chronic disease, self-management. Had to put Tai Chi in there, of course, of things that actually work at improving outcomes for people that we haven't necessarily thought of because we didn't consider them medical enough in nature. And I think with all of this, you've heard me, you can tell I'm an optimist, that it does improve health outcomes for people and in the end, hopefully improve quality of life. So I appreciate the opportunity to speak to all of you today, and I look forward to hearing what my co-panelists have to say. Thank you.